subscribe now and press the bell icon. Never miss an update.
Good evening and welcome to Health Live at Seniors Today. If you have been going through the montage that we just played, you would have seen our guest today who has been on our sessions. He's taken 2 sessions with us in the past. Of course, it's been a while since he's come to our show, come to our Health Live session. But we welcome Dr. Paresh Pai. Dr. Pai is a senior vascular and endovascular surgeon. Before I welcome him, I would like to introduce him. He is, as I mentioned, a senior consultant vascular and endovascular surgeon at the Breach Candy, PD Hinduja, Lilavati, and Bhatia Hospitals in Mumbai, with over 2.5 decades of experience in the management of cerebrovascular diseases, distal small vessel reconstruction in atherosclerotic and diabetic limbs, venous thromboembolic disease, and endoluminal treatment of aortic aneurysms. Dr. Pai is former treasurer and secretary of the Vascular Society of India. He's a past consultant vascular surgeon at the Westmead Hospital in Sydney in Australia. Today, we've invited Dr. Pai to speak about deep vein thrombosis. This is, as it happens, the Deep Vein Thrombosis Awareness Month, and we have asked him to speak about DVT, as it's called, prevention and care. Welcome to Health Live at Seniors Today. Once again, Dr. Pai.
Thank you so much, Mr. Maheshwari. Indeed, a pleasure to be here with you and your members. And in fact, last time I did interact with a couple of them when they had come and seen me after having the webinar, I think in 2021 or 22.
Right.
So yes, it's indeed a pleasure to be here with you again today.
And thank you. And we have now, as you can see, we have already got 66 people who are watching it, and this number goes up to around 100. And there are around 700 people who are watching it on YouTube as well. So it is picked up since the last time you came here. So happy to inform you that. So over to you, Dr. Pai. So as always, Dr. Pai will make a presentation on DVT, and I must alert you that this presentation is going to be, this entire video is going to be recorded, so you don't have to make notes, etc. If you have any questions, please ask them at the end. Do remember that all these questions, all sessions like these are advisory in nature. If you do have a specific problem, well, you can ask over here, but there's nothing to beat a clinical examination, etc. Doctors like Dr. Paresh Pai are available for a teleconsult. Of course, it's best to have a personal consult, but you could do that as well. Over to you, Dr. Pai.
Thank you. Thank you so much. Right. So today's session, we're going to focus on thrombosis, and that's basically that involving the venous system. Right. So when you look at thrombosis means blood clot. And this is a normal process which is actually protective, bleeding from these blood vessels whenever they get injured. But sometimes you get these clots in situations where you don't want them to take place, and that could involve various sites. So you can get a clot in the heart arteries, where you get what is called as a myocardial infarction or a heart attack. You can get in the brain, where you get stroke. You can get lungs, where it's called pulmonary embolism. You can get peripheral arteries in the legs, where you get blood clots in these arteries, reduced blood supply, and you can end up with gangrene. Or you have clots in the veins. And the veins can be either in the legs, it can be in the abdomen, or it can be in the brain, or other sites also. So today we will be focusing on venous thromboembolism, or VTE in short. And this includes a blood clot in the deep vein, such as a vein in the leg, or a blood clot in the lung arteries. See, the veins, what happens is the veins carry blood back to the heart, and there goes to the right side of the heart, and from the right side, it goes to the lungs. So all this becomes one unit, because the lung then acts as a filter. And that's the reason why we group this together as venous thromboembolism. So that includes deep vein thrombosis and pulmonary embolism, or PE in short. So what exactly is deep vein thrombosis or DVT? So this is the formation of a clot in one of the deep veins of the legs, and it's usually in the muscles. The veins are in the muscles, and that's why they are called deep veins, because they are situated deep inside the legs. It commonly occurs in the leg. However, it can occur elsewhere in the body, as I've already mentioned before. So here you can see that there's a blood clot in the deep veins, and from there it can break off and it can go up. So DVT is an underrated disorder in India. There used to be a common misnomer that, it's not common in India, it's more common in Caucasians, but that's not really true. Unfortunately, we don't have the exact incidence of deep vein thrombosis in India, unlike the Western world, where they have a lot of this is government regulated and funded, so they have a better idea of what kind of incidence they have. Sometimes there's also less awareness in the medical fraternity, and especially it's important when things are taken for granted and you're not aware of the possibility and think along those lines. VTE is a preventable cause of morbidity and mortality, and there are some important facts. So Indians and Asians are affected as much as Westerners or Caucasians. Many times the deep vein thrombosis and pulmonary embolism is silent, so it's missed. Medical patients are as much at risk as surgical patients. And like most things in life, prevention is more important than treatment. Unfortunate truth is the prophylaxis for prevention of deep vein thrombosis is not adequately followed. So, in fact, so much so that if there is inadequate prophylaxis or there is no prophylaxis, there is a potential risk of having a lawsuit because of medical negligence. So one has to be very, very careful when you think about patients who are prone for deep vein thrombosis. Unfortunately, another fact is that the treatment of deep vein thrombosis is inadequate in most cases. And the fact is that surgeons and patients perceive that problems related to postoperative bleeding as a surgical complication, and deep vein thrombosis or pulmonary embolism following surgery is not related to the surgery and it's actually a medical problem. So that's not true. If there are precautions, it also becomes a complication post surgery, and you have many cases where the surgeon's done an excellent job, but without adequate prevention or prevention, people end up with a blood clot, and that can be life-threatening. So VT often goes undetected until it is too late, and less than half of all cases of fatal PE are detected prior to death. So approximately 80% of DVT is clinically silent, and it's the proverbial iceberg where you see only 20% outside and 80% is hidden inside. This is a very important study called the ENDOR study, which tried to look at what is the risk of VTE and what is the prophylaxis in the acute hospital setting. This involved 358 hospitals over 32 countries. The patient at risk of VTE, overall risk was about 52%, of which majority 65% were patients in the surgical ward and about 41.5% in the medical ward. Interestingly, patients who ended up with DVT, you found that 45% of surgical patients had DVT and 55, so 10% more in the medical ward had ended up with DVT. DVT prophylaxis was overall used in almost half of patients. But here's the interesting part. Because of the awareness of the risk of DVT in the surgical patients, almost 60% ended up with prophylaxis, and only 40% of medical patients ended up with prophylaxis. Low molecular weight heparin, LMWH, was not used in medical patients where there was a risk of bleeding and there was liver impairment. And in surgical patients, it was not used whenever there was bleeding or there was risk of intracranial bleeding. The lowest use of prophylaxis was seen in Bangladesh, Thailand, India, and Pakistan. This is a very interesting paper which came out from Chandigarh, where it looks at autopsy of patients So the incidence of pulmonary embolism contributing significantly to the death of patients is almost 12.6%. Sepsis infection was the primary diagnosis, is almost 1/3 of total cases, and 42% of patients who succumb. Pulmonary embolism affected a younger population as 80% of the overall patients. So it's not that it's only in older patients, but it's also seen in younger patients. 66, that's 2/3 of the fatal cases in group 1, and 73% of combined cases, group 1 and 2, were below the age of 50 years. And that is really a cause for concern. There is another study which was done. It's called as the PROOF study, or the Prospective Registry of Venous Thromboembolism. And the data was collected from 19 countries and almost 3,500 patients, of which 667 patients were of Indian origin or from India. And here you found that the prevalence of various factors causing presenting with DVT was 8% of varicose veins patients had DVT, whereas in the other countries it was 22%. Acute care hospitals was 54% in India versus 36% or 1/3 in the other countries, which tends to suggest that there's not adequate prevention taken care when the patients come into the hospital. At home, India, 43% versus 60% in other countries, probably because patients may be delaying going to the hospital or going to the hospital only when it's absolutely necessary. Idiopathic, that means unknown causes, were seen in 43% of cases in India, and other countries was 44%, so it's more or less same. Provoked, that means there was a causative factor, was seen in almost half the cases in both India as well as other countries. And recurrent deep vein thrombosis was seen in 6% of patients in India and 9% in other countries. What were the other findings? Again, here you can see that the VTE prophylaxis was only given to 5% of patients who presented with DVT. Only 5% didn't have DVT prophylaxis. That's very small. Other countries, you had 12%. So let's understand, how does DVT or pulmonary embolism present? So typically patients present with swelling, pain, the foot becomes, or the leg becomes a little warmish, and discoloration of the leg. Pulmonary embolism presents with shortness of breath, chest pain, coughing, and sometimes blood in the sputum. Pulmonary embolism occurs when clot from the leg breaks off and goes to the heart and is lodged inside there, blocking the blood supply and causing shortness of breath. So as I mentioned, you get dyspnea, that is shortness of breath, cough, sweating, palpitation, wheezing, chest pain, blood in the sputum, collapse, leg pain, leg swelling. These are all things that one needs to be careful or suspect that there may be pulmonary embolism in these type of patients. So how does this actually pulmonary embolism take place? What is the link between DVT and PE? So the deep vein thrombosis is typically formed in the clots just under the cusp of the vein. The veins are provided with unidirectional walls. So these valves, you get clots which start there, and they gradually propagate and become larger. And with movement or with straining, especially when you get clots involving the veins going higher up in the abdomen. So when people strain, when they go to pass motion or they go to the toilet, you can squeeze the clot out and send it off to the heart, to the lungs. So the strong relation between DVT and PE, approximately 50% of patients with proximal deep vein thrombosis have asymptomatic pulmonary embolism. DVT, mainly asymptomatic, is found in 80 to 90% of patients with PE. So that's where the clot has come from. And risk of PE after acute DVT lasts for almost 6 the clot or DVT takes place. So this is very important. That means that despite best medical treatment, the risk persists for 6 weeks. That's 1.5 months. So what are the risk factors for VTE? So if somebody has a previous history of blood clot, that's a risk. Family history of deep vein thrombosis or clots elsewhere, clotting disorders, whether inherited or acquired, obesity, tobacco or cigarette use, varicose veins, all these can cause problems or a risk of DVT. Other factors, which include prolonged immobility, surgery or trauma, increasing age, pregnancy, and poor cardiac function or respiratory function can also predispose to VTE. So many factors can increase your risk of developing deep vein thrombosis. More the number of risk factors, more the chances of deep vein thrombosis. Patients undergoing surgery that lasts for more than 1 hour duration are the most common risk factors. Inheriting a blood clotting disorder, familial transmission is there. Prolonged bed rest, long hospital stay, paralysis, inability of the calf muscles to contract causes stasis of blood flow and promotes blood clots. Injury or surgery, as mentioned, can also increase the risk. Pregnancy. Pregnancy comes because of two reasons. One is that there is pressure on the veins in the pelvis and legs by the gravid uterus of the baby, and there is a tendency for some blood to protect the mother when at the time of the delivery. So the blood tends to be a little more sticky. And this continues in post-delivery in what is called as the in the postpartum period, puerperial period. Other causes include drugs or medicines like birth control pills or oral contraceptive pills or hormone replacement therapy. Obesity increases the pressure in the veins in the pelvis and legs, can also cause clots. Smoking affects blood clotting and circulation. And cancer. Some forms of cancer increase the amount of blood clotting factors in the blood. And this is something called as cancer-associated thrombosis. Heart failure. Limited heart and lung function causes blood to clot in the veins. Age of puts you at higher risk. Sitting for long periods, driving for long periods, office work, or the famous economic class syndrome, when you do long distance travel, sitting in the blood, sitting in the chair in the aircraft causes this. So it is very important that as physicians, we risk stratify every individual who comes to the hospital. And according to this, you have levels of basic risk and you have levels of acute risk. And this is important because this tells you what is the chances. So you have somebody with low risk and you have somebody with very high risk. So once you classify the risk stratification of a particular patient, you decide what is the best way of preventing it. So before we go into prevention, let's just understand how deep vein thrombosis or VTE is diagnosed. So this is done with a combination of blood tests, clinical examination, blood tests, and some imaging studies. Done is called as a D dimer. Now, very interesting thing that a negative D dimer is extremely useful because it rules out presence of deep vein thrombosis. But a positive D dimer may mislead you, saying that there is a clot when there is no clot. So typically somebody who gets an injury can have blood clotting in the tissues or what we call hematoma, and that itself can cause the D dimer level to go up. Infection, sepsis, that can also cause the D dimer levels to go up. So a negative D dimer is extremely important and useful to rule out DVT, but with a positive D dimer, you have to see again the values, and you can also see about the other imaging studies, which gives us an information. So this includes what is called as a Doppler ultrasound. And this is an extremely important test which tells us what is the status of the veins and if there is any clot in the veins. People who are obese have a lot of swelling. Sometimes it's difficult to make out what's happening. And you may need to reduce the swelling and then cross-check. So suppose you have a negative Doppler and a negative D dimer, then you are pretty sure that there is no deep vein thrombosis. Sometimes we do what is called as a venogram, where you inject a dye in the vein to identify if there is any clots there. Lifestyle modification and other measures are also important because they help you prevent deep vein thrombosis and PE. So maintain a healthy body weight, avoid prolonged periods of inactivity, regular exercise, minimize alcohol, smoking. maintain and control your blood pressure is very useful. Mechanical measures of using vascular compression stocking. These are special stockings which are tight at the ankle and less tight as you go up. So the squeeze is below upward. So that prevents collection of pooling of blood in the legs. Sometimes you may use intermittent pneumatic compression boots or devices, which gives pumping and improves the flow in the legs. So what are the goals of treatment in VTE? So one is prevent an existing clot from getting bigger, prevent the formation of new clots, provide symptomatic relief, give cosmetic improvement, prevent a clot from breaking off and traveling through the bloodstream into the pulmonary circulation, and minimize or prevent long-term complications. So these are the objections. So to this, prevent DVT, prevent thrombus formation, extension, prevent pulmonary embolism, the disease, post-thrombotic syndrome, and prevent pulmonary hypertension. So again, if you remember, I had mentioned that depending upon the level of risk, you decide how you do. So if the risk is low, you don't need to do any special prophylaxis. Moderately risk, you use anticoagulation, use stockings, use compression devices. High risk patients, you give a higher dose of heparin with compression stockings. With very high risk, you give a much higher dose of anticoagulation with intermittent pneumatic compression. So this is that pump which I was telling you about. So prophylactic, see to it that you take the proper medications that have been advised by the doctor. Avoid sitting still for long periods. Try to get moving as quickly as possible. Try not to sitting with your legs crossed or with the legs bent. If you can't stand, then at least exercise legs. I will show you how. So here you can see that you can lift your toes and lift your heels. That improves, that is activating the calf pump. And that sees to it that the blood keeps flowing and doesn't stagnate there under the valves. Foot pump exercises are as mentioned here. Lifestyle changes involves losing weight, quitting smoking, getting regular exercise. Now, treatment options. Now, there are two or three factors that we consider. First is whether the patient is young or an old, because your treatment options will change, because in the older patients, the risk of having complications is more with the treatment. Then it depends on what is the onset of presentation. Is it an early onset? So that is within 7 to 15 days. Is it subacute? That means 2 to 6 weeks. Late presentation when it's more than 6 weeks. Also, we see what is the extent of deep vein thrombosis. Is it involving only the calf veins? Is the calf veins and the thigh veins involved? Other pelvic veins, or is there a pulmonary embolism? Then severity of symptoms and the response to simple treatment also helps us decide what's the best treatment options. So this involves anticoagulant drugs. We do what is also called aspiration thrombectomy and thrombolysis. So here we use various devices or a catheter to suck out the clot and then leave a medicine which dissolves the clot. Rarely we do cable interruption procedures, and sometimes more often we use what is called IVC filter, inferior vena cava filter. So this is like a jali which sits into the vena cava. And if clot breaks off, it stops it from going to the lungs, especially the big clots. Sometimes we do surgical thrombectomy where you pull out all the clots. Very rarely that's done. There are other essential measures which can be used, which includes using class 2. Class 2 means tells you how tight the stocking should be. Graduated compression stockings. Sometimes we also do a thrombotic profile, or if we suspect that there's a chance of malignancy, we check for malignancy. And there are many patients who presented not with the malignancy, but present with deep vein thrombosis or pulmonary embolism. And on checking, we find that they have a malignancy somewhere. At a later date, we also check for treatment of the stenotic or occluded iliac veins, so that you improve the venous return from the legs to the heart. We correct deep venous reflux, and we also correct reflux of the superficial and the perforator veins. So what is the need for anticoagulation therapy? The simple thing that whenever there is a small clot, it starts a chain reaction. This is the trigger factor. It affects the calcium and what is the thrombin, and this causes a net to be formed and the blood clot to start increasing. So typically this is called propagation of the clot. So anticoagulation by thinning the blood results in reducing the risk of further clot formation. So what is the ideal upfront therapy? We look at that. When to start warfarin or NOAC is also what we look at. So normally in the old days, we used to use unfractionated heparin, which is a basic form of heparin, where it's given as a bolus and as a continuous infusion, and you monitor to see whether the blood is adequately thrilled or not. So this is quite a bit of a pain because you have periods where the therapy is going on, but the anticoagulation is not adequate. So then you have to adjust the dose. So there's a lot of time wasted. There are other options now, which is called low molecular weight heparin, where we use, based on your body weight, we decide the dose. And that is very good because that does not need to be monitored the way you do unfractionated heparin. There are other drugs also called fondaparinux, where you can use, which is given as a single dose per day. And we have newer oral anticoagulants or non-vitamin oral anticoagulants, vitamin K antagonists. These are oral medications, and this has revolutionized how we do the treatment now. So here again, you have an option of using either vitamin K antagonists like warfarin or acetron, and you have the newer anticoagulants like dabigatran, apixaban, rivaroxaban. So, word of caution here. As a principle, we never start with just warfarin or acetron. We start with a low molecular weight heparin, and then we start warfarin so that the blood becomes the blood becomes thin first. Warfarin, what it does is that initially you get a period of hypercoagulability, that means more clotting, and then it becomes, it starts anticoagulating. So that is the reason why we start with low molecular heparin first, and then we monitor and check whether the warfarin effect is adequate before stopping the low molecular heparin. So now there is much easier way of doing it, provided the patient is able to take oral anticoagulation, and secondly, that the kidney function is good. So the advantage of these newer oral anticoagulants is that there's no monitoring required. You don't need to do blood tests again and again to see whether the blood is adequately thin. You don't need to change the dose. There is no dietary restriction. When you were taking warfarin and you could not eat palak, karela, cabbage, cauliflower, green leafy vegetables. There were fewer drug interactions. It does not react as much with other, and it's a shorter half-life. That means the effect lasts for a short time, and you need to take the drug. There's no limited antidote, that is the only drawback. But because it's much safer, the need for antidotes is less. So here you have the option of Protexam. This is one of the drugs which is used, and it is used in the dose of 150 milligram twice daily. This is one of the drugs which has an antidote, and that antidote can be used whenever you want to reverse it. You can use different doses depending upon whether it's for hip surgery or for knee surgery, or if special population where you can reduce the dose, especially if you have patients with more than 75 years of age, or if the renal impairment is not there, or patients are taking some special drugs like amidro or verapamil. The other drug which is used is rivaroxaban, goes by the name of Xarelto. That's the original molecule, which has all the tests which are done. Here we start with 10 milligrams. So you don't need, in dabigatran, you need to give low molecular weight heparin first and then change to dabigatran. In Xarelto and the other drug which will follow now called apixaban, you don't need. You can start with the drug. You start with a higher dose. You start with 15 milligrams twice daily. And then once after 3 weeks or so, you reduce the dose to 20 milligrams once daily. For prevention, you use 10 milligrams once daily, and that works and is very safe. The other one is apixaban, also called as so that also goes very well. So it starts with 10 milligrams twice daily for 7 days, and after 7 days, you reduce the dose to 5 milligrams twice daily, and that works very well. This has a much higher safety profile as compared to rivaroxaban or dabigatran. And it's also the drug of choice if you have somebody with renal impairment or you have somebody with cancer. After 6 months, if there's no cancer, you can reduce the dose to 2.5 milligrams twice daily, and that can go on for life or for a longer period. So this kinds of gives you a summary of what the whole options are. enoxaparin, low molecular weight heparin is given in the initial phase, and then you change to dabigatran or warfarin. And extended you give for a continue with the same dose. Or if you are sticking to only one drug and oral preparation, you use apixaban or rivaroxaban, as mentioned before. So what are the treatment options for VTE? Okay. So besides anticoagulation, there are other things that can be done. So if the clot is very big, if there is a lot of swelling, responding to anticoagulation and other treatment, you have the option of sucking the clot out. So it's called aspiration thrombectomy. And this is a special catheter which is used to suck out the clot. Or you have special devices called mechanical thrombectomy, which is used. And we also use thrombolytics, where the drug is delivered directly into the clot and dissolves the clot. As I mentioned before, you can also add an inferior vena cava filter, which captures the clot and prevents it going to the lungs and reduces the risk of death. So this is one patient where we used aspiration thrombectomy. Here you can see the clot being sucked out. That's the catheter going there, and you can see the clot being pulled out. Here you can see that after we have cleared the clot, once we clean out the section, we go up and we clean out the next part of the clot. You can see the clot being pulled out. And this is the clot which is coming out, and you can see the extent of clot. There are about 3 or 4 of these, which gives you this thing. Here you can see the clots cleared out, and you can see that it's narrowed there. Here you can see the narrowing at this point. So once we establish a through channel, we use the thrombolytic, and we give what is called RTPA, which dissolves the clot. And along with that, we also give heparin to prevent new clot formation. And here you can see that the clot has cleared off and there's a narrowing here. And then we use a stent here. You can see the stent being deployed. And there's a large stent. And there is deployed so that it corrects the narrowing. Now you can see how quickly the flow is. The narrowing is no longer there. And you can see that the whole entire length of the vein is completely cleared out. So we do this not only for clots in the legs, but we also do this in the lungs. And with that, we give the anticoagulation and use either warfarin or the newer anticoagulants. We give stockings, we repeat the Doppler, repeat the CT angio, complete and confirm that there's complete clearance of pulmonary embolism. So here you can see that there is a clot there. The next picture will be much better. There you can see the clot there. So this is my neighbor who had this. That's his clot, big clot involving one side, the left side of the main pulmonary artery. And after treatment, you can see that the clot is completely cleared out. So what is the take-home message? Blood clots in legs are common, especially if one is unwell, traveling, there is infection, there is weakness or poor function of the heart or lungs, and following some surgeries. This can be very life-threatening. It damages the valves and veins after the clots are absorbed. And this can be prevented by using either pumps, stockings, medicines. Can be sucked out and dissolved if diagnosed early, particularly in young patients, because the risk of bleeding is less. And may need blood thinning from anywhere from 6 months to 2 years to even life. And now there are newer medicines which are available that are easy to use. So what I've tried to do is give you an idea that it's a multidisciplinary team effort which gives the best results. It needs a lot of dedication and patience. And what is important is to aim high but play safe. Thank you.
Thank you very much, Dr. Pai, for a very detailed presentation. As always, you have, I think, answered most of the questions that are there. We have had around 196 people right now, and perhaps a few more before. There are a few questions that have come in, and I'll just try to ask them to something that you're not repeated. This is from Mr. Dinesh Paliwal. He says, what precautions to be taken while undertaking 14 to 16-hour flights, especially in the economy class for senior citizens, say above 70 years?
So there are some things which are very easy to do. and some things where you may need to get your doctor to help you out. So generally, long flights, see to it that you wear compression stockings so that you speed up the flow. See that you drink plenty of fluids. The drinking plenty of fluids does two things. One is it reduces the thickness of the blood, so it dilutes it. And second is because of drinking plenty of water, you are forced to go to the toilet. So naturally, you don't sit in one place. You have to go to the toilet and come back. So that itself becomes an action and prevents the deep vein thrombosis. Now, if somebody has a special case where there is heart function which is affected or lung function is not very good, so in those cases, we can use either Xarelto in the dose of 10 milligram once daily, or we use apixaban, which can be given as 2.5 milligram twice daily. So once a day dose is much easier to take, and you can take it for 2 or 3 days. So one day before you start your flight, the day of the flight, and then you can take it for a day or two after. So all that helps you prevent deep vein thrombosis during long travel.
Right.
And of course, the exercises, which I told you about.
There's a question from Radha who asks, are varicose veins and spider veins the same?
Yeah, it's spider veins are the very, very early form of varicose veins. And they are either spider veins or called telangiectasia, and they are just involving the dermal part of it. And generally, they may be associated with veins under the skin in the subcutaneous tissue or the fat. So yes, they are one and the same, but just a different extent. The larger veins bulge out and you see them. Spider veins are just seen, and spider veins can also be seen following hormonal changes.
There's a question from Kalpana Gupta. I have Raynaud's phenomenon. Is it similar to what you're discussing now?
No, not at all. Raynaud's phenomenon is a phenomenon where there is, normally when you're exposed to cold, the body tries to conserve heat. So it does that by causing the veins to narrow down or go into spasm. Now, sometimes the spasm that you take place, or more than spasm, it's a compression. So sometimes the response is exaggerated, and that causes the foot, the end, usually is either hands or legs, whichever is exposed, causes the digits to become white or sometimes even blue, and it can be very painful. And normally, once you get out of the cold, this is supposed to be relaxed. But in the exaggerated form in Raynaud's, it persists for a longer period. So the simplest thing to do is put your hands in, either warm the hands or put it in a bowl of hot water, not hot enough to cause burns, but not lukewarm. And that causes the veins to reopen up or the blood vessels. So it's mainly arterial rather than venous.
There's another question from Bomi who asks, Doctor, for varicose veins, should we wear compression stockings throughout the day or only when outdoors?
So ideally, it depends on the extent of the veins and what you're doing. So typically, if you're standing or if you're sitting for long periods, you should ideally wear stockings. And you should wear it first thing in the morning and remove it last thing at night. You don't need stockings unless you're partying and you're standing for long periods. If you're lying down, you're eliminating gravity. And that is the reason why the stockings are not useful at that time or not required in that situation.
Doctor, one last question from Vijay Ganduri, who asks, is aspiration thrombosiotomy done under sedation? Can this be repeated if required? And what's the success rate of cure or recovery?
So, very good question. So before you do the aspiration thrombectomy, what we do is we put a filter so that if at all you're removing the clot and a clot breaks off and it's not picked up by the catheter, so there's a risk of it going up. So that is the reason why you put a filter first. Secondly is you clean it up. You can do it as many times as you require. But if it is done properly, then generally the need to do it again is less. Another factor is whether this is the clot which taken place the first time or this is an acute on chronic. If it's an acute on chronic, in other words, if the clot is old, it becomes very hard and does not cannot be sucked out or cannot be dissolved. So therefore, it's important to know the age of the clot, and that you do by finding the history as well as by your ultrasound findings, which can age the clot. So fresh clots are what are called echolucent. That means they look black. They don't give much echoes. Whereas old clots give you echoes back, and therefore you can make out the age of the clot.
Doctor, this is one question, and this is a final one, which is from Akori Bitunjay Kumar. He says he's 73, and he says inflammation in the legs have started after sitting. Is there any advice to him?
Yeah, so this typically will start if there is leakage or a special type of varicose veins, where what happens is there is high pressure in the system, what we call venous hypertension. Normally, we say hypertension is high blood pressure in the arteries. But in the venous system, you can have high pressure because of many reasons. One reason, especially in the elderly, is if there is water retention. Water retention results in high pressure, water accumulation in the venous side, and therefore you can get inflammation. You can also get because of varicose veins, or you have what is called perforator incompetence, which comes up and causes the limb to become hot, red, and then gradually becomes black. And it looks like inverted champagne bottle. So it's big at the top and narrow at the bottom where the scarring takes place. There's also associated a lot of pain, burning, and sometimes itching. And when you scratch, you might end up with a wound that does not heal. So these are the things that you have to be careful about. And mainly in the elderly, you have to be careful of a situation called as fluid retention. And that is seen in somebody with either a liver problem, problem with cardiac, where the heart pumps well, but doesn't relax properly. Or it can be seen in somebody with liver issues, liver problems, where there is again inability of the blood to hold the water and it releases it and it comes and accumulates in the legs and causes leg swelling.
Thank you very much, Doctor, for your time and for a very detailed presentation.
My pleasure. Thank you.
Very fact that you have had so many.
Pleasure to be with you again.
Yeah, we would, of course, as always, come to you again for another session on another topic.
Sure.
Again, thank you very much to all of you for being here and coming here in large numbers. We will be back once again next Saturday at 5 p.m. We have a doctor from on ENT who is going to be speaking as per the request that we have received from all of you. So do come in next week, next Saturday at 5 p.m. And we look forward to meeting you again. Thank you very much again, Dr. Pai, for being here.
Thank you. Goodbye.
Bye.
Subscribe now and press the bell icon. Never miss an update.